Hello everyone, welcome back to my channel Untangle ENT. Today's topic of discussion is tuning fork. We all are aware of tuning fork and its various uses, but here, through this video, I will help you clearly understand the basics, mechanisms, give you some explanations, and also provide you some exam tips. What a tuning fork? A tuning fork is a metallic acoustic instrument which has two prongs attached to a stem which produces pure tones of known frequencies when stuck. Based on the frequency, it can be 128 256 Hz, which are of lower frequencies, and they provide more of tactile stimulation of vibration. Then there is 512, which is best, which has minimal bone overtones, optimal decay time. Then there are higher frequencies like 1024, 2048, and 4096 Hz, which have short decay time and less durability. So, what are the tuning fork text used for? It is used for assessment of hearing, detection of malingering, and some non ENT uses like neurological use. The tuning fork is activated by striking it gently against the examiner's elbow or heel of the hand or rubber heel of the shoe. For testing of the air conduction, the tuning fork must be placed vertically in line with the external auditory canal at a 2 cm away from the opening of the external auditory canal. Now when you vibrate the tuning fork and place it like this, the sound travels to the external ear, middle ear through the tympanic membrane, and then it reaches the cochlea and goes through the auditory pathway to the brain. For the bone conduction, after vibrating the tuning fork, the footplate is placed firmly over the mastoid process and the cochlea gets stimulated via the skull bones. So when we place the tuning fork, the sound directly travels through the cochlea and through the auditory pathway to the brain. Now the exam tip is, normal hearing through the air conduction is louder and twice as longer compared to the bone conduction route. Why air conduction is more than bone conduction or louder than bone conduction? In bone conduction, the vibration directly reaches the cochlea and stimulates it. So, first, it has to face a very high air fluid resistance at the cochlea, and second, it lacks the amplification and the impedance matching and transformer mechanism which is provided by the tympanic membrane and the middle ear cavity. Now, this thing is seen in case of air conduction where the sound travels through the external ear through the tympanic membrane into the middle ear cavity, which gives a resonance. There is impedance matching and transformer mechanism which amplifies the sound while it reaches the cochlea. Therefore, the air conduction is louder than the bone conduction in a normal scenario. Now let's learn about the tests that are performed using tuning fork. So first is the Rinne's test, where the tuning fork is vibrated and placed over the mastoid tip, and the patient is asked to raise their hand when they stop hearing, and immediately thereafter the tuning fork is brought in front and placed in front of the external auditory canal parallel and 2 cm away, and the patient is asked to raise their hand when they stop hearing. Or we can ask the patient which was louder, the first one or the second one. A Rinne's test is called as positive when air conduction is more than bone conduction, which is seen in normal hearing or can also be seen in sensorineural hearing loss. Why Rini is positive in sensorineural hearing loss? Now suppose in sensorineural hearing loss, there is some problem in the cochlea or in the auditory pathway. So when we place the tuning fork over the mastoid process, the sound stimulates the cochlea directly. But if there is a problem in the cochlea won't be stimulated and the sound won't be passed and there won't be the passing of the vibrations. But the air conduction, the vibrating tuning fork is placed in front of the ESC. The sound is passed through the external ear, tympanic membrane, and the middle ear. Sound is amplified. And there is resonance. There is impedance matching. So some sound is heard. AC is still reduced because of there is problem in the cochlear and auditory pathway, but some gets heard. So therefore, AC becomes more than bone conduction. Now, Rinne's test is considered as negative when bone conduction is more than air conduction, which is seen as conductive hearing loss. Why Rinne negative in conductive hearing loss? In the air conduction pathway, the conductive pathway is blocked, which can be at the level of external ear, or it can be the level of the tympanic membrane, or it can be at the level of the middle ear due to some pathologies in either. But the bone conduction is pathway is normal because it is going through the cochlea directly to the auditory system. Therefore, the bone conduction is better than the air conduction system. Therefore, we get a negative Rinne's in case of conductive hearing loss. So Rinne's test, it can either be air conduction more than bone conduction or bone conduction more than air conduction. Air conduction more than bone conduction is called positive, seen in normal cases or in sensorineural hearing loss. The negative is seen in conductive hearing loss. But there can also be false positive, which is seen in cholesteatoma or profuse discharge, or it can be false negative, which can be seen in severe unilateral sensorineural hearing loss. So why Rinne false positive in profuse discharge? In profuse discharge, suppose the tympanic membrane there is a perforation and there is profuse discharge filling all of the external auditory canal, and when we place the vibrating fork, the sound travels through this liquid or the fluid and goes into the middle ear cavity. Therefore, the patient gets a better hearing. But after the operation or after the disease is cleared, the hearing loss increases. So patient might complain that my hearing has increased. Therefore, the disclaimer is, if there is profuse discharge in the ear, we have to clear the discharge and then do the hearing assessment to get an adequate or correct finding of the hearing assessment. Why Rinne is false positive in cholesteatoma? Suppose in the middle ear the ossicles are eroded, but there is cholesteatoma which is filling up this eroded ossicles area. So the sound gets traveled from the external ear to the middle ear into the inner ear. But after the surgery or the disease is cleared, the sound won't travel. Again, the patient will complain that the hearing is reduced. So for this case, we have to beforehand counsel the patient that there is cholesteatoma, there might be a problem with the hearing. We have to clear the disease first and then consider about the hearing part of the patient. But why Rini is false negative in severe unilateral sensorineural hearing loss? Now see, AC and BC both are absent in severely diseased ear with sensorineural hearing loss. But on bone conduction testing, there is transcranial transmission of the sound. So if you place the tuning fork over right mastoid, it will get transmitted and the patient will hear the sound through his left ear. Now see this, tuning fork is placed, the sound through this side is stopped. The sound gets traveled through the opposite side and the patient hears it through the opposite side. Therefore, we get a bone conduction more than ear conduction and gives a false negative result. We can correct it by giving a masking sound on the non-tested ear by a Baronese noise box, or we can convert it through the other test which is called as the Weber test. There is a rule of using these different frequency tuning forks in Rinne's test, that is the 256, 512 and the 1024 Hz. And if we see the airborne gap, suppose 256 we get a equal or a negative results, but the other two the result is positive. Consider it as an airborne gap of 20 to 30 decibel. If both the frequencies are negative but 1024 it is positive, there is an airborne gap of 30 to 45 decibel. And if all the three are negative, then there is an airborne gap of 45 to 60 decibel. So a negative Rini means a minimum of 15 to 20 decibel airborne gap is there. Therefore, different frequencies will help to assess the threshold of hearing loss. Next is the Weber test. The vibrating tuning fork is placed in the middle of the forehead vertex and the patient is asked in which ear the sound is heard the most. In a normal condition, think this is a patient and the vibrating tuning fork is placed. The sound gets traveled through the skull bones to both the sides and patient has a normal hearing. Now suppose there is left-sided conductive hearing loss. We place the vibrating fork and the sound gets traveled to both the side. But in the left side, the air conduction pathway is blocked due to a blockage in his middle ear or external ear or the tympanic membrane. Therefore, the person only hears the bone conduction sound nicely. But on the opposite side, the air conduction pathway is normal. So the air conduction sound clashes with the bone conduction sound. So bone conduction sound is not clearly heard. So in this case, the sound gets lateralized to the deceased ear, that is with the ear with the conductive hearing loss. But in case of a sensorineural hearing loss, the cochlea is deformed. Even if you place the bone conduction, the vibrating tuning fork, the bone conduction will not travel because the cochlea is deformed. But on the other side, the cochlea is normal. The sound gets traveled through that. So the sound gets lateralized to the better ear in a case of sensorineural hearing loss. Next is the absolute bone conduction test, which is a measure of the cochlear function. Patient's bone conduction is compared with the examiner's. The procedure is ask the patient to close her external canal by pressing the tragus and then place the tuning fork over the mastoid tip. When the patient stops hearing, place the tuning fork over your own mastoid tip while keeping the ESC closed by pressing the tragus. Important point is the examiner must have a normal hearing to do this test. The finding are simple. In conductive hearing loss, the duration is same because bone conduction tests your cochlear pathway. The air conduction pathway is blocked, so in conductive hearing loss, both will be same. But in sensorineural hearing loss, the duration will be reduced in patient because the sound won't be louder or won't be heard for a longer time because the cochlea or the other pathway is deformed, but the examiner will hear it in a normal time. Schwabach test. Bone conduction is compared with the open external canal. In this, in conductive hearing loss, the duration is lengthened. In sensorineural hearing loss, duration is reduced. In normal condition, both are equal. But why lengthen bone conduction in this test? The bone conduction is tested, but EAC is open, so the ambient noise also enters. So for the examiner, this ambient noise clashes with the bone conduction and the bone conduction sound is heard less. But in the patient, the air conduction pathway is blocked because of conductive hearing loss and he hears the bone conduction in a better way. So the bone conduction is lengthened in the patient. Next is the Bing test. Test of bone conduction examines the effect of occlusion of external auditory canal on hearing. The vibrating tuning fork is placed on the mastoid while examiner alternately closes and opens the external auditory canal by pressing the tragus inwards. So what do we see here? We compare the EAC occlusion with EAC open. In normal case, the patient hears louder when the EAC is occluded as compared with the EAC open condition. In sensorineural hearing loss also, patient hears louder when the EAC is occluded than in EAC open. But in conductive hearing loss, there is no change. Now why is this? Because when the EAC is open, the air conduction clashes with the bone conduction and the sound heard is very lighter. The bone conduction sound is heard very less. Same happens when there is sensorineural hearing loss. But when there is conductive hearing loss, the conductive pathway, external auditory canal, tympanic membrane, middle ear is already blocked. Even if you close or open the external auditory canal, it won't affect the hearing provided by the bone conduction. So this condition is called as a pinch positive. The last is the Gillies test. It is a test of bone conduction. It examines the effect of increased air pressure in the external auditory canal on hearing. The air pressure in the external auditory canal increased by Siegel's speculum. Now see this, EAC is sealed with Siegel's pneumatic speculum and the pressure in the EAC is increased. If there is a normal middle ear stiffness, we place the vibrating tuning fork over the mastoid while pressure is changed in the EAC using the Siegel's speculum. The air pump pressure is changed from plus 200 to plus 100 and like that. And when we increase the pressure, the TM and the ossicles are pushed inward, which causes an increased intralabyrinthine pressure. And this causes the immobility of the basilar membrane and thus there is decreased hearing. But if there is altered middle ear stiffness like ossicular fixation or any ossicular discontinuity, even if you increase the air pump pressure in the middle ear space using the Spiegel speculum, there will be no change in the tympanic membrane, no change in the middle ear space, and therefore there will be no change in hearing. So Gillies test three conditions: normal, sensorineural hearing loss, and conductive hearing loss. In normal condition, it is considered positive because hearing decreases with change in pressure. And sensorineural hearing loss is also positive. The hearing decreases with change in pressure. Only if there is middle ear stiffness or ossicular fixation, like in otosclerosis, it will be negative because hearing does not change with the change in pressure change. Finally, summarizing the whole thing, will help you in your exam. So Rini's test, the normal is air conduction is more than bone conduction. In conductive hearing loss, bone conduction is more than air conduction. And in sensorineural hearing loss, it is AC more than BC. Weber test, in normal condition, it is in centralized. In conductive hearing loss, it is lateralized to the poorer ear or the diseased ear. In sensorineural hearing loss, it is lateralized to the better ear. For absolute bone conduction, normally it is same as the examiner. Conductive hearing loss, it will be also same as examiner, but in sensorineural hearing loss, the sound will be reduced. In Schwabeck test, it is equal for the examiner and the patient. In conductive hearing loss, the sound is lengthened. Sensorineural hearing loss, it is reduced. Bing test, for normal, it is louder. For conductive hearing loss, there won't be any change. And in sensorineural hearing loss, it will be louder. Next, Gillies test, for normal, there will be air conduction more than bone conduction. In conductive hearing loss, there will be bone conduction more than air conduction. And in sensorineural hearing loss, it will be air conduction more than bone conduction. That's all. Thank you. If you like this video, please like, share and subscribe to my channel Untangle ENT.